introduce Dr. Sangeet Mittal. He is the director, Vitreoretina Thin Eye Hospital, Jalandhar, Punjab. He did his fellowship in Wear Surgery and was awarded the V.T. Joshi Gold Medal for the Best Fellow. Did MS Ophthalmology from PGH Chandigarh in 1995. Best of the Show Award at EVRS for 3 consecutive years, 2017, 18, and 19. All innovative videos. 3 awards at AIOS and CS Rashmi Award Video, ET Selvan, the Best Poster Award, and the AIOS Trauma Award at recently concluded AIOS2021. He also won the JM Power Best Paper Award at VRSI 2009. I would request Dr. Mittal to give his talk on oral fluorescein angiography.
So, Mike, yeah. Thank you, Dr. Anirudh, for the kind introduction. So good afternoon, everyone. My talk for today is minimally invasive oral FFA using broadline imaging technology. Fluorescein angiography, as we all know, has been in vogue since 1961. And it uses the injection of fluorescein dye to study the vascularity of the retina, and different lesions are diagnosed on the basis of the hypo or hyperfluorescence of the lesion. But even today, after more than 25 years of my practice in vitreoretinal, the only one thing that I am still jittery of doing is the fundus fluorescein angiography. Not because of the procedure itself is difficult, but because of the complications that are associated with FFA and the fear of injection that exists in the mind of the patient. It's very difficult to convince him to undergo FFA. FFA, lots and lots of problems: allergy to the dye, nausea or vomiting, urticaria, anaphylaxis in some patients also, and even rarely 1 in 22,000 patients have lost their life also after FFA. Again, a vasovagal syncope just because of the fear of the injection, and again, it is limited use in bronchial asthma, nephropathy, and pregnancy. Ultimately, FFA becomes an invasive, not easily repeatable investigation, and the fear of injection exists not only in the mind of the patient, but also of the technician or the doctor who is doing the FFA. So oral FFA is not a new procedure. It was first use of oral fluorescein angiography was reported in 1979 using the analog fundus camera, but the image quality was not very good. Then Hara et al. In 98 reported using oral fluorescein angiography using a digital fundus camera. Image quality was better, but still not acceptable in certain diseases. Then SLO was also used to do oral fluorescein angiography. Again, the good quality images with CSLO were seen as compared to film-based fundus camera. And Dr. Rajvardhan Azad et al. In 2006 reported using OFA using CSLO. They also said good quality images with CSLO as compared to digital fundus camera. But another problem of using oral angiography was the availability of the oral tablets of fluorescein that were being used to do this fluorescein angiography procedure. So broadline fundus imaging by Zeiss in Zeiss Claris, what is it? It uses a broad rectangle of light which is scanned across the retina and detected using a monochromatic camera. So true color images are generated through sequential illumination by broad spectrum red, green, and blue LEDs. And this gives a true natural looking fundus as it appears through direct observation. And by using a slit to only illuminate a portion of retina at a time, broadline fundus imaging limits the amount of unwanted scattering and reflections from the eye, thus enabling imaging a wider field than classic fundus cameras, which eliminates the whole field simultaneously. So the difference between the CSLO and broadline imaging is that it gives you a true color images as compared to the CSLO based images. And the normal fundus camera, the whole of the fundus is illuminated simultaneously, but in broadline fundus imaging, it is a sequential imaging, and then all the images are stitched together to form an ultimate photograph. So we have used this oral fluorescein angiography using broadline imaging ultra wide field camera. We use 445 eyes of, this is a slightly older data, about 2 years old. 236 patients underwent fluorescein angiography. And the dye was given in the dose of 25 milligrams of per kilogram body weight. So what we used were, we used the same ampules which we use for intravenous angiography. We used the same ampules. The dye was dissolved in 30 ml sugar-free juice, which was followed by another 30 ml of juice without the dye, just to change the taste, which is bitter, a little bit bitter. The dye is a little bit bitter. And then the angiograms were taken at regular intervals every minute for first 5 minutes, followed by every 2 minutes for 5 to 10 minutes, followed by every 5 minutes up to 30 minutes. And we obtained good quality images in almost 95.3% of patients, and average quality images in 3.8% of patients. So almost 99% of the times we got good quality images, average to good quality images, which gave us the diagnosis quite comfortably. And the earliest images we were obtained were ranging from 1 minute 30 seconds to 26 minutes 25 seconds, but mostly it was in the range of 8 to 9 minutes that we used to get the first image after giving the oral fluorescein dye. And we compared it with our previous patients who had undergone IVFFA. The complication rate was quite less. The nausea and vomiting was less than 1%, which was as high as about 6% in the IVFFA. So most of the unpleasantness that is being seen in your clinics while doing FFA just goes away. Hardly any patients we see of nausea and vomiting after giving the oral fluorescein angiography, after doing the oral fluorescein angiography as compared to IV. There was a mild rash in 1.27% patients. And the difference in the IVFFA and the oral FFA in this allergy component was that in IVFFA you used to get the rash immediately within 20 minutes, but in oral FFA the rash is slowly, it develops after 20 minutes, and so you just have to keep a patient a little bit longer in your clinic to follow up whether he's developing any allergy or not. Severe allergy, in none of these patients, whereas in 3 patients we had a severe allergy in the IV FFA group, and the vasovagal syncope, none, because there was no injection involved, but in IV FFA it was quite high, 1.19% was significantly different. So comparing oral FFA with IV FFA, oral FFA is safer, it's less invasive and comfortable, the preparation is faster and can be performed by technician itself. It can be easily repeated. Patients do agree to get even after a month, if I ask my patient to get a FFA done, he is he goes ahead with it. Then in pediatric patients, the children are very easily, you can convince that you can, because they are very afraid of those injections. In patients who are contraindicated to IV injections, you can do an oral FFA, and you can even do multiple procedures simultaneously because the dye takes time to wash off. So you can do 2-3 patients simultaneously, just keep them altering one by one on the fundus camera. But IVFFA still is a standard, and you get a better arterial and choroidal phase only on the IVFFA, and definitely it takes lesser time. You just finish up the procedure in 5 minutes time. But as I told you, because of the oral FFA, you can do multiple patients also together. So the time comes out to be the same. So some patients in pediatric, it's easier than IVFFA because it's well tolerated and children do resist IV injections. So these are some of these patients you see. This is the oral FFA which is done in a patient of Coats disease, a 7-year-old girl who had Coats disease, and you see a good quality images present. There was a cystoid macular edema. You can make out the peripheral aneurysms, and you can make out the peripheral leakages, exudates on this. So this is a patient of FPVR. You can see that typical torchlight bulbs in the periphery, and on this. So this can be easily used in children. So this is a patient of branch retinal artery occlusion. Though I told you that arterial and choroidal phase you can't capture with the oral angiography, but you can still make out that on an oral FFA that some of the cattle tracts that are present in the arteries. So these days, in the presence of OCTA, when you say where does this oral FFA will stand against the OCTA? So oral FFA is minimally invasive, whereas the OCTA is totally non-invasive, but the oral FFA is a dynamic procedure. And OCTA is a static procedure. So the lesions in which there is no blood flow, you miss while you do OCTA, like microaneurysms or the macroaneurysms. But in dynamic, for the OFA, but for the oral FFA, it's dynamic. You can see the leakages in CSR. You can see the leaking microaneurysms very clearly. And subtle lesions can be picked up easily, which again can be missed with OCTA. True extent of disease can be picked up with the oral FFA, and these cameras are wide field cameras, so you can do it even up to the periphery. And it's again easier in patients with poor fixation. The people who have got the OCTA know the patient who has got a poorer vision, it's very difficult to get a good quality OCTA image in those patients. But OCTA still I feel is better for the CNVM, is faster, and again better follow-up you can do with the OCTA. So this is a patient in which dynamic angiography I'll show you. You see this patient, the dye came in 9 point, you can see the hotspot forming, and you can see the leakage, the smokestack appearance, leakage in a CSR. Then again, this is an ink blot leakage in a patient of CSR. You can see the dye coming into the hotspot starting to appear at 9 minutes, and it increases in the intensity and size later on. And this was another patient of CSR. You can make out the hotspot and the leakage of the dye. So in uveitis cases also, you sometimes need a dynamic angiography. In this patient of serpiginous choroiditis, you can see there's an early hypofluorescence followed by a late hyperfluorescence. So you can't get these pictures on OCTA. This is a patient of APM PPE post-COVID vaccination, and again you see on OCTA you can't pick up these lesions, but on oral FFA you can see that there's an early hypofluorescence of the lesions which later leak on and get hyperfluorescent. Then for exudative AMD or classic CNV, I still say that OCTA is a better investigation tool, but though you can still make out on oral FFA also, you can see a leaking CNVM present inferior to the fovea in these patients. Then for retinal macroaneurysms, again you can pick them up on oral FFA other than on OCTA. For very subtle lesions like these subtle new vessels, you see the fundus picture, you can hardly see any new vessels in these, but you see a lot of NVEs present in there. Then for subtle NVDs, again, you see OCTA won't give you a true extent of the picture, but oral FFA, you picked up a lot more than this. So this was a patient of diabetic retinopathy. You can see capillary non-perfusion in the periphery, which can be easily missed on OCTA. So this was a patient who had a bilateral CRVO, and you did an oral, you can see the patient was of Takayusu's arthritis, classic peripheral non-perfusion in Takayusu's arthritis. So you can pick up these patients. Then Dr. Shobit has already highlighted the use of the wide field angiography. And you can even do this oral FA with a normal digital fundus camera, and you can still get very good quality images. For diabetic retinopathy, I'll just rush through these slides. For diffuse macular edema, you can pick up the leaking capillary blood. You can pick up the ischemic macula. You can pick up capillary non-perfusion. So diabetes is one of the most common disease for where you have to do an angiography. So you can pick up very subtle NVDs, even in patients of asteroid hyalosis where OCTA does not have any role. You can pick up good lesions after beyond that. Then again, the limitations of this oral FFA, very heavy patients, you won't get very good quality pictures. In like more than 100 kgs patients. Then patients who had a history of recent meal, within 1 hour, you don't get good pictures, and patients with significant cataract, you don't get good pictures. So to conclude, oral FA is a safe, less invasive, well-tolerated procedure with high sensitivity. Quality images can be obtained in about 99% patients and can be performed in most indications. And to obtain a comprehensive evaluation in common retinal diseases and to reduce risks and discomforts of the IVFA, oral FFA may be considered for clinical purposes. Thanks a lot. Thank you.
Thank you, Dr. Mittal, for an excellent presentation. Well, I have a few questions. Like, what is the time we need to wait till we get a good picture in this oral fluorescein angiogram?
So if we see the range is from 1 minute 30 seconds to 26 minutes. In the study that we had done, But most of the patients who had their first images was about 8 minutes to 9 minutes, 8 to 9 minutes.
So we need to make the patient sit and check out whether the images are coming.
You can decide on clinical basis in which patients you need a very early image, or in which patients even the AV phase is okay for you. Like in diabetic retinopathy, sometimes even the AV phase is okay. You don't need the arterial and the choroidal or the very early images. In those cases, you can ask the patient, you wait, I'll take an image after 8 minutes, so get the good picture at that time. Or you can, what we generally follow nowadays is we start every 2 minutes, we take for the first 10 minutes, and then every 10 minutes after that.
Sangeet, do you alter the dose in a early nephropathy patient with mild to moderate nephropathy, or oral dose is fine?
We have kept it the same, sir. I asked my nephrologist, and he said there will be no problems.
Yeah. Because many times they advise us to do a half dose when we are doing IV.
Yes, sir, but the clearing definitely takes a longer time because large amount of dye is given to the patient. So the patient stains yellow after this for about 6 to 7 hours.
Any case of anaphylactic shock, which
No patient.
nothing.
No severe allergies, no shock, no vasovagal. No.
so the
Only
side
1 or
effects
2
are much
patients-
less.
Yes, much less.
Much less. The only drawback is, I think, the time.
Time
That's
is
it.
the main. But then you can club your patients. You can have your 3-4 patients sitting together, and you start the FFAs and just keep them altering one by one to the fundus camera.
And I think you mentioned in your presentation the filling delay cannot be evaluated with this oral
Yes.
angiogram.
Yes.
So that's the two
That's a
drawbacks.
true drawback.
And regarding you have immense experience in this oral fluorescent angiogram. So do you feel the image quality is almost the same as an IV angiogram, the conventional one?
Yeah. Yes. Yes. Yeah, you can use them. IV with as compared to IV, yeah, it's same. It's same. No problems. I asked my nephrologist when we started this thing, and he said you can use it freely, no problems. You are giving, but the absorption is, I think, still lesser as compared to the IV. So the amount of dye that is going into the bloodstream almost the same.
Could you please tell us about the instrumentation? Could you please highlight on the instrument, exactly what are you using? The regional fundus camera, or what kind of camera are you using to capture this?
So I've used both. I had used the digital fundus camera by the Carl Zeiss team, and now I'm using the Zeiss Claris, that is the broadline imaging technology by the Zeiss again. So you can use it on digital fundus camera. I showed some pictures of the digital fundus camera also.
And where do we get this fluorescent tablets? Like, is it easily available?
No, these is not tablets. So these are the same ampules.
Okay.
These are the same ampules that you use for the IV in a 25 milligram per kilogram body weight. You mix it with the orange juice and give it to the patient for injection.
Okay. And do we have any tablets? That's what we were mentioning in our presentation.
We had tablets,
Okay.
but it's not easily available.
So any questions on the wide field angiogram?
I just want to ask you one question.
Yes, sir.
Have you used ICG also in the
Claris?
Claris system?
Not yet, sir.
And okay.
I think there's a technical difficulty in incorporating ICG into Claris because they are using light as the scanning system. But they are coming up with a short modification. I think within this year only they will.
Yeah, because that's just what I was wondering.
Yeah.
Because I still use the Heidelberg system for all my
Yes.
ICG, and it's SLO based.
So oral FFA works very well with the Heidelberg also, and with the the Optus also. I have used that also.